So we are. My job is to discuss about a topic which has been a bottleneck for medical oncologists for a very long time. But now, with the development, we have got now some treatment for the same. So, so definitely, this is a ASCO G update, as we are all know. So definitely, updated data for the survival is now available, and we'll be presenting the same. Can we move to the next slide? So this is the actually long-term follow-up data from the Javelin Bladder 100 trial. So this has been a game changer study, and it is basically first-line maintenance treatment for urothelial cancer with avelumab. And initially, multiple approaches have been tried, but finally, this approach has proven that use of platinum-based chemotherapy in the upfront, followed by use of immunotherapy with avelumab maintenance. And this is the study which was based on the overall survival endpoint, and we'll see the updated data with this study. We all know Tim Powles. Powles is a well-known oncologist from Bart's Cancer Institute, and he is the first author of the same. So let's move ahead. So this study design is very simple, which is somewhat different from the complex immunotherapy trials. This is based on simply the use of chemotherapy with gemcitabine cisplatin or gemcitabine carboplatin. Both chemotherapy and both platins were allowed, either cis or carbo, and the patients who were unresectable or locally advanced metastatic urothelial were included in this study. And the patients complete response, partial response, a stable disease with the standard treatment of 4 to 6 cycles. So up to 6 cycles were allowed. 4 cycles were minimum. They were after an interval of 4 to 10 weeks. Around 700 patients were enrolled in the study. 1:1 randomization to receive avelumab as the treatment along with supportive care, and rest the other arm received supportive care alone, which was considered at that time the standard of care. And the patients were given treatment till progressive disease or unacceptable toxicities or withdrawal by the either PI or the patient. The point to note is that PD-L1 positive tumors were close to 358 patients. So nearly half of the patients were having PD-L1 positive disease. So we'll see whether PD-L1 positivity is making any difference or not. And another very, very important point which I wanted to highlight here is the primary endpoint of the study. Most of the studies are designed to address progression-free survival in such scenario, but to the contrary, here we can see the primary endpoint was overall survival. So that is a very, very heartening to see. The immunotherapy trial included all randomized patients. Also, PD-L1 positive was included and primary analysis population. As I told, PFS and safety, these are very important secondary endpoints, and these were included as secondary. Stratification was done as per best response to first-line treatment, that is CR, complete response, versus CR or PR versus stable disease. And also metastatic site when initiating first line of treatment, visceral versus non-visceral. So these two are very important prognostic factors, and these are included as stratification factor to balance the study so that it is free from any selection bias. So let's see ahead. In the next slide, we'll see. So these are the results. The data cutoff, which is the final, this is updated survival data cutoff date was taken to June 4, 2021, and median follow-up was 38 months. This is another important point which should be kept in the back of mind. This there is a significant follow-up period of a long follow-up period of 38 months. And this is even you can see the confidence interval are also not very wide. That means that most of the patients had very good follow-up in both the arms, avelumab as well as supportive care. Now, treatment was ongoing in 43 patients in the avelumab arm and 10 patients in the best supportive care arm. So close to 12% patients were on treatment, and 3% patients of supportive care alone were on treatment. And the most common reason for discontinuation, as we can understand from the poor biology of the disease, is disease progression. So most of the time patients progress very fast on cisplatin and carboplatin based chemotherapy, and this is what we see after discontinuing the treatment. The most of the time the disease progression is the most common reason in actually both the arms. Median duration of oral avelumab treatment was close to 25 weeks, and around 20% had received more than 2 years of avelumab treatment. So more than 2 years avelumab, that means around 1/5 of patients receiving so significant benefit. That is very, very important to see. If a drug is able to give more than 2 years of follow-up progression-free survival with avelumab, that is clearly evident. 1/5 of patients are getting extraordinary benefit. This is somewhat different from the other immunotherapy. What happens in most of the study, 20% patients get benefit, but they are getting so long-term benefit. It is not always the rule of the thumb. But here, what is the point? That very important to see that these patients are able to receive long-term treatment with more than 2 years of avelumab. Let's see further data in the next slides, and these are very, very important data. So this is the primary endpoint of the study. As you can see, at 2 years data, 38% versus 49%, that means close to 50%. In fact, 12% difference in overall survival at 2 years, and this is also sustained at 3 years overall survival and cutoff. You can see 29.8 versus 36%. So you can see there is wide difference in the curve, and this is starting as early as 4 months. So this is, you can see that difference starts very early and is sustained throughout, and towards the end of the study, when the number of patients become very less, still the difference is sustained. So if you see the median PFS of 15 months versus 23.8 months, so 8 months, at least 8.8 months, close to 9 months survival difference, that definitely it is like close to nearly 1.5 times, 1.75 times the survival is prolonged. So that is very important. And even we'll see how many patients were able to receive immunotherapy in the next line. That will also come. If we see the PFS in the overall population, 2 years PFS was 7% versus 23%, and 5% at 3 years versus 16% at 3 years. So this is again the same story as PFS, but OS is also getting so significant prolongation, and it is very, very statistically significant and also clinically relevant to us. Let's see further data in the next slide. Definitely it helps us in selecting a drug based on the, if we see this forest plot, you can see all the points are nearly towards the left. That means in favor of avelumab. In only very selected patients where numbers are very low, the curve might be somewhat heavier. It can be towards the right. In one curve we can see, but it doesn't make much difference. You can see that overall all the points are towards the left. That confirms that all the subgroups of patients are getting benefit, irrespective of the various stratification factors, whether presence of visceral disease or not, presence of GFR. Even patients who are received cisplatin or carboplatin, all are getting benefit in terms of survival benefit. So this is very, very heartening to see a drug working so well in nearly all the subgroups of the patients. This is actually very important for us. Let's see some further data from the study in the next slide. And this is what you can see, the complete response rates, best response to first line treatment were close to 40% in avelumab arm, and around 27% in the BSC alone arm. And patients with partial response were again 19.2% in avelumab, with BSC it was 12.8. So definitely OS best benefit, you can see it is present irrespective of best response to first line treatment, because we sometimes get the questions from the our colleagues and juniors whether the patients who are having complete response also require maintenance treatment. Yes, you can clearly see there is definitely improvement in the survival from 26 months to 39.8 months. So what better you can achieve with a treatment with avelumab, with an immunotherapy drug? Even patients who have received CR with chemotherapy are having significant survival benefit, and this is very important. And you can see, and the maximum number of patients are in the partial response arm. That is why the data is, seems to be very strong and powered for this, and it is achieving statistical significance as well. So in the let's move to next slide. So, but the message is very clear. All the patients are getting benefit. If you see patients who what was the further treatment which was given subsequent anti-cancer therapy? This is also an important point to understand and receive, that patients who were in the best supportive care alone arm, 53% patients received PDL1 inhibitor in the next line. So that means this is not a chance derivative. What happens if the patient is on supportive care alone arm? Most of the time, a significant number of patients will drop out and they will not be able to receive the next line of treatment. That is the main concern, and that is why we want to start the treatment before the patients become so sick and they progress so badly that they are offered only supportive care. But in this study, this is the benefit. With avelumab maintenance, we are able to take care of that as well. And even in supportive care alone, more than 50% patients received PDL1 inhibitor, and FGFR inhibitors were offered to close to 3% patients. And ongoing drugs, as I told, ongoing treatment in avelumab was close to 12%. So this is very, very important for us. Let's move to next slide. So to conclude, the long-term follow-up from the Javelin bladder trial, with more than 2 years in all patients follow-up, as I told, it continues to show prolonged overall survival and progression-free survival with avelumab first-line maintenance versus supportive care alone. And overall survival, as to be remembered, is close to 50% in the avelumab arm at 2 years, and it is close to 38% in the supportive care alone, making a difference of close to 12% at 2 years. And 2-year PFS rates were also significantly improved from 7% to close to 25%. So that is another big data. And if we are counseling the patients, such data is actually very important while we are counseling. Otherwise, patients might not understand the benefit, because sometimes medians are misleading in case of immunotherapy. But here the medians are also very wide. But in some immunotherapy trials, median is somewhat misleading. But 2-year database percentage are usually important, and what we can see here, 2 years progression-free survival 7% versus 23%. If you are reporting to a patient, mostly the patients, if having resources, definitely will agree to the same. And also, as I told, overall survival patients receiving more than 50% patients in supportive care are receiving immunotherapy. So don't think that subsequent treatment will alter the outcomes, and it is what we are able to see. And if we see the long-term safety data of avelumab, it is a very standard one, around 20% of patients receiving more than 2 years of treatment, and a low rate of discontinuation due to treatment-related adverse effects. And no new safety signals were identified from this data. So these results continue to support the recommendation of avelumab first-line maintenance as a standard of care for all patients with advanced urothelial cancer that have not progressed on first-line platinum-based therapy. So definitely the message is very loud and clear, and the data is very, very convincing. So I think this was the last slide. So this is, let's see some subgroup analysis data. This is in the Asian patient subset. This is important because every time we in the trials of lung cancer and other cancer, we try to see how our patients have done, how Asian patients have done. Let's see the data from this study. This is actually a subgroup data from the same study, Javelin Bladder 100 study from Amito et al. Next slide. So this subgroup analysis was done because around 21% patients were Asians, and baseline characteristics, as you can see, these are also very well managed between the two groups, the two treatment arms. So this is very, very real, and even the subgroup data for Asians is also very fine. Next slide. And we are happy to see that there is a separate Asian subgroup analysis which has been separately presented in the ASCO, and it is useful. Again, you see, though definitely these are a smaller number of patients, so the data study might not be powered enough, but you can clearly see the median OS difference seems to be the same as in the overall population, that is 18 months versus 25 months. And here definitely the confidence interval will not cross, will cross 1 because the data is smaller, and the 95% confidence interval will be wide, but still the median values help us to understand that the overall benefit seems to be similar. And it is the PFS data again, the separation is curves are wide very easily, 1.9 months versus 5.6 months. So it's a huge difference, three times improvement in the progression-free survival. Next slide, please. So definitely the data is very, very strong. And if we see the toxicity in Asian patients, grade 3 or more adverse effects were seen in 44% patients versus 16%. 16% patients in supportive care alone are also having grade 3 or grade 4 toxicity. This is understandable because these patients will develop anemia and other toxicities like pyrexia, vomiting. These might occur. And definitely maximum important side effects, grade 3, 4 adverse effects with avelumab, if you see, it is close to 10% with anemia, and increase in amylase levels, grade 3 is close to 5%. And others are small numbers, grade 3 adverse effects are small numbers. And if this is any grade adverse effects, this will total somehow to be somewhat high, but that is not making a difference in terms of clinical toxicities. And adverse effect leading to death was small, only 1.4%. Let's move ahead. So this again concluded that their safety is good and consistent with the overall population, no new safety signals, and efficacy was demonstrated in the Asian subgroup as well. The data supports even in Asian patients. So with this, I think we can conclude here. Next slide. And this is, ARIES trial data from the ARIES study. This is a first line in PD-L1 positive metastatic subgroup. This is another subgroup which we wanted answer. And this is subgroup analysis from the ARIES trial gave us some highlights that whether use of avelumab maintenance in first line in PD-L1 positive patients is having giving any difference. And patients who were given avelumab maintenance with 10 mg per kg and given avelumab treatment with 10 mg per kg. This is first line avelumab data. The patients who are unable to receive treatment with any platinum, that is the ARIES trial. So this is a different from the trial of Javelin trial, where it was used as a maintenance treatment. This is the first line avelumab data. And this data is also for cisplatin unfit patients. And cisplatin unfit, we are aware, PS2 or PS2, EGFR less than 60, grade 2 or worse peripheral neuropathy, and previous cisplatin for neoadjuvant or adjuvant treatment with progression within 6 months. So basically, definition of cisplatin refractory disease was followed. Let's move ahead to find the slide. And this is the primary endpoint. This is actually a phase 2 design. So median overall survival is close to 10 months after a median follow-up of 9 months. And patients alive at 1 year was again very significant, 41% with median PFS of 2 months. As I told, in phase 2 studies, immunotherapy medians might not give us the best answer. And we need to see how many patients are getting survival at the particular time point. Among 71 PD-L1 positive patients, the differential PD-L1 expression has been evaluated by CPS, and the patient, 56 patients had CPS of more than 10%. And definitely the median was 13 months for patients with CPS more than 10 compared to 7 months those with CPS less than 10. So again, the role of CPS is coming when the patient is receiving first line treatment, and this is not so maintenance treatment. So it's very, very important. OS difference was seen. This happens. This is seen with our immunotherapy trial again in some cases, and this is proof of concept for the same as well. Let's move to next slide. This is the waterfall plot, which helps us to estimate that more than 50% patients are getting decrease in the size. So this is really important, and you can see from the waterfall plot, and the safety is very similar from all the trials. Adverse reported events in around 5% or more. Let's see further. Next slide. So yeah, so just to conclude, first line avelumab maintenance reported activity in patients with advanced urothelial cancer unfit for cisplatin-based treatment, overall response rate of 22%, disease control rate of 43%. The ARIES trial clearly showed that patients with CPS score more than 10% had maximum benefit, but the survival difference was not so much. And patients who had dismal prognosis but use of avelumab led to a significant improvement in the same. So next slide. This is the LEAP-1 data, first line Pembro with or without lenvatinib, and this trial I will be very brief with the same. And if you see the Pembro data, Pembro addition, lenvatinib addition was tried, but there was no significant difference in terms of overall survival, and this data has significant benefit, and we can see the same. Let's move to the next slide. So this, as I told, addition of lenvatinib did not show any anti-tumor activity, additional anti-tumor activity to Pembro alone. That is why this is not further being considered. So I think as I am exceeded time, I will stop here. Thank you.